Bismillahirrahmanirrahim. Okay, so today's topic is twin gestation. So basically, a twin pregnancy can occur either with two oocytes. It's saying that there can be two oocytes, two eggs, which are fertilized by two different sperms. So there will be a dizygotic twinning. There will be two types of zygote, or from the division of a single zygote, that is a single egg fertilized by a single sperm and forming a single zygote, and then it splits into two different uh, sections. So it is a monozygotic twinning. Dizygotic twin, they have different genetic profiles. That is, fraternal twins होते हैं and they may be same or different sex. While the monozygotic twins are the same sex, they are genetically identical to each other and in appearance. Basically, what we think of when we hear the name twinning. So, twin gestation are most commonly subdivided by chorionicity and amnionicity. Chorionicity means how many chorions, how many placenta they have, and amnionicity means how many amniotic sac they have. So, here is a pictorial demonstration. So, it can be a monochorionic, monoamniotic twin, which is a single sac and single placenta. It can be dichorionic, diamniotic, like the basically the monochorionic, monoamniotic have the complication of conjoined twinning. It can be dichorionic, diamniotic, two different sacs, two different placenta. It can be monochorionic, diamniotic, that is they have a single placenta but two different sacs. And if it can be diamniotic, dichorionic, so they have different placenta and different sac. So the distinction is important due to increasing risk when placenta or amniotic sac are shared. They are separate, no problem. There are other complications, but if they are fused, there are complications like conjoint twinning, twin transfusion, and okay. So, uh, diamniotic twins is referring to pregnancy in which each has its own amniotic sac, and amniotic twin can be separated into dichorionic, diamniotic, and monochorionic, diamniotic. Okay, so monochorionic, that's a different game. Understanding the development, and that's it. And prevalence and risk factor. Twin pregnancy can make up to 3% approximately of live birth, and most common type of multiple gestation. So almost 70% of the twin are dizygotic, and 30% are monozygotic. So the kind of twins which come into our mind, those are more rare. Those are only 30%. Dizygotic twins are always dichorionic, diamniotic. Okay, they have different sac and different placenta. And monozygotic twin, they can be either one of those. So this is a monozygotic twinning, and they will have a single zygote which will split, and they can form into the either category. Risk factor for twin gestation include, first of all, the increased maternal age. The typical scenario will be a woman of 30 plus age, 40 plus age. Reproductive assistance like clomiphene, use of clomiphene, yeah, ovulation induction, in vitro fertilization, increased parity, G7, P6, uh, things like that, and family history of twinning, that is also important. This risk factor is the risk for dizygotic twinning due to ovulation of more than one ovum, except for in vitro fertilization, which raises the risk of both dizygotic twinning and monozygotic twinning, because it's quite expensive process. We cannot take the chance. So there are multiple ovums which are fertilized and then overlooked as to which one converts into a zygote due to transfer of the multiple embryo, and monozygotic twinning due to increase the risk of embryo cleavage. So physiology, this is boring stuff. Dizygotic twinning, they will undergo uh, fertilization. They will two different zygotes and they will go through all the processes. Can we have separate placenta or fused placenta? Okay, so now the one thing, the thing is the ultrasound sonography. USG is diagnostic, that is critical in first trimester because this is the optimal time to determine the amniosity, that is the number of amniotic sac. Okay, and curiosity. Basically, we have three types of scans, right? Dating scan, anomaly scan, and then there is a scan that comes after that. So during the first trimester, we can establish the diagnosis of the twin gestation. So monochorionic monoamniotic are diagnosed by a lack of a dividing intervening membrane. They will have a same single sac. Monochorionic, that is single placenta, and diamniotic twins, they are diagnosed by T sign, which occur when both amniotic layer meet at the shared placenta at 90 degree. This will be like this. So this is a T sign. Both amniotic membrane are conjoining at this point. So this will be a T sign. And oh shit. Just a sec. So, and dichorionic, diamniotic gestations, usually two separate placenta in appearance of fused placenta identified by thick intervening membrane and placenta projection where the intervening membrane meets. Basically, you will see lambda sign. Now, this is the lambda sign. There will be fetus 1, fetus 2, and lambda or peak T sign. This will be that sign. Okay, so this is the T sign, this is the lambda sign. Now when it comes to the management, the risk of multiple gestation, the risk is divided into two categories: the maternal complication and the fetal complication. Maternal complication include the hyperemesis gravidum, a typical scenario that is women in eighth week of gestation, uh, and having excessive vomiting and dehydration and lost greater than 5% of the pregnancy weight. These are diagnostic point for the hyperemesis gravidum. Okay, so and it occurs in the first trimester. Iron deficiency anemia because there is increased load, and preeclampsia, eclampsia. This is one of the major causes of the need to induct labor because of the preeclampsia and eclampsia occurring in the twin pregnancy. So most of the twin pregnancies does not complete the age of gestation. And gestational diabetes mellitus and cesarean delivery, two fetus are difficult to pass out, and postpartum hemorrhage might be due to it might be due to placenta accreta associated with it, or multiple placenta retained conceptus. And the fetal complication, the preterm delivery, I have already explained, it is mostly due to the preeclampsia eclampsia we have to induce. The second cause of this is the increased number of oxytocin receptor, that also leads to preterm delivery, and it is one of the most common complication of the twin gestation. Now, the fetal growth restriction, transfusion, or more people, more nutrient requirement, the reasons like that, and congenital anomaly, like I have already explained, when there is a single sac and single placenta, there are more chances of the conjoined twinning. Okay, and again, this is the lambda sign you've seen in the dichorionic diamniotic twin gestation, and this is the T sign in monochorionic diamniotic pregnancy. So this is all the things we have already discussed. Because of the increased risk of stillbirth, weekly third trimester antenatal testing, that is non-stress test by BPS, biophysical profile, is performed depending on the underlying risk and type of twin pregnancy. Monochorionic twins are at risk for additional and serious complications. A monochorionic meaning those who have single placenta. So there is twin transfusion. This is a twin transfusion. One will be the donor and will undergo oligohydramnios, and the other will be the recipient and will undergo larger size and polyhydramnios. Okay, this one, the larger one can undergo hydrophytalis, and the donor one, that will result in stillbirth. Okay, arteriovenous anastomosis. Monochorionic, monoamniotic twin transfusion, cord entanglement, single shared placenta, And hydrophytalis, I've already explained that. Acha, the important point, it will undergo the fluids in every category: pleural effusion, skin edema, pericardial effusion, hepatomegaly, ascites. So that's quite deadly. A quick quiz: the hydrophytalis, in which infection is it seen? So it is parvovirus infection, most common. Mode of delivery: higher risk for cesarean, and monochorionic monoamniotic should never be allowed to deliver vaginally due to the risk of cord entanglement. They have a single sac and a single cord. If you can deliver one, the other will get entangled or undergo birth asphyxia. So it should be planned as a C-section, and a blood vessel occlusion of remaining inside to twin. However, vaginal delivery may be appropriate for dichorionic diamniotic, different sac, no problem, or monochorionic diamniotic, single placenta but single placenta but uh, different sacs. So these are the criteria. However, vaginal delivery may be appropriate. There are criteria. The presentation is cephalic, no breech presentation or things like that. And second twin may be either cephalic or breech, or breech extraction can be considered if the fetus is greater than 32-week gestation, concurrent in size and weights greater than 1500 grams. So presenting twin must be cephalic, and the second twin can either be cephalic or breech. So a breech extraction can be done, but there is a risk of being converted into a C-section. So prognosis for twin pregnancy is largely dependent on the chorinosity and the amniosity. Basically, I have seen a scenario in which the patient was planned and was brief. Here in Pakistan, even after that, if there are complications after explanation to the whole family, there are things like FIR and things like that. It's the fault of the doctor. So the prognosis very heavily depends upon the chorionicity and amnionicity. The scenario, the case I was talking about was the monochorionic monoamniotic scenario. So it is a very high risk twin pregnancy. So dichorionic diamniotic twins have most favorable outcomes, whereas monochorionic or diamniotic and monochorionic monoamniotic are at increased risk of stillbirth, neonatal morbidity, mortality, birth asphyxia, cord entanglement, etc. Because of the spontaneous preterm labor and medically indicated deliveries, more than half of all twin pregnancy deliveries occurs before 37 week of gestation. So twin pregnancy are high risk pregnancy with increased risk of dependent on the chronicity amnioticity of the pregnancy. Dichorionic diamniotic, those are managed like a singleton pregnancy, but the scenarios we have discussed, it the presenting fetus should be of cephalic presentation. The second one can be of cephalic or breech. We can attend the breech presentation, but there is a risk of even after that being converted into a C-section. And monochorionic diamniotic pregnancies are at high risk for complication, including twin transfusion because of shared placenta. Monochorionic monoamniotic pregnancies are highest risk. The monochorionic and monoamniotic are at higher risk due to cord entanglement, which is predictable and can be rapidly fatal. And understanding of the various type of twinning pregnancy and the management of the specific complication can help mitigate the risk. So that's all for the twin pregnancy.